And then we failed our final swallow study. What this is they try various different textured foods to try and see if she'll eat them and see what she does. We did not pass, and we have not eaten since. Some concerns with this are that it always has to be kept clean. The G-tube can come out. She's actually kind of fascinated with it. She loves pulling on it when she's able to. But also, she's a 2-year-old, which means if she goes on plays, it can get snagged and come out that way. Some of the more interesting nights have actually been when we've realized that the G-tube was on the floor and we didn't know how long it was there for. We actually managed to make it all the way from 1792 and 436 to Florida Hospital South in 5 minutes.
Nice.
And thankfully we got it back in. When the G-tube is taken out, the stoma, the hole in the stomach, starts to close immediately. Within hours, it is too small to replace the G-tube. Within 24 hours, it is completely closed, which means that you would not be able to get anything in there. Anything after a couple of hours, and you're looking at a brand new surgery. Thankfully, we had some good doctors over there at Florida Hospital South. They managed to get something in there. Actually a little Foley where they blew up the one end and tied off the other one just to keep the hole. And then, poor baby, they took different sized catheters and started putting them in one after the other to dilate the hole until they could get it wide enough for the G-tube to go back in. It sounds rough, but the alternative was another surgery. And that's not something anyone wanted to do. She is completely G-tube fed. She does not eat or drink by mouth. She does not take medications by mouth. There aren't a whole lot of medications at this level we give pediatrics, but she can receive nothing. Most of the medications that we have are on a G-tube formula, and the other ones that we're looking at are going to have to be crushed up and put into the tube that way.
When you crush them up, do you mix them in with something or just?
I don't have a good answer for that yet. That's the new medication for epilepsy that we're going to be looking at. We're actually supposed to get it today or tomorrow. I'm assuming we're going to put it in with some water, probably.
Okay.
Some other concerns, the skin is sensitive. She is still 2 years old. And since it's an open port to the stomach, that means that you have constant irritation by stomach acid at the site. It does need to be kept dirt-free, and it can be snagged and pulled out. That's actually why we have these up here. This is a G-tube pad. It's just a little circular disc with a hole in the middle and a snap on one end, so we can put it around the G-tube. It kind of sits underneath it, and that will kind of absorb anything that comes out, as well as trying to keep it dirt-free. This right here is a belt, a little Velcro, and whenever she's, anytime actually, we have the belt fast firmly over so she can't access it, so it doesn't get caught on anything, and actually those two things right there made life a lot easier. If you see a child with a belt though around here, you can expect they probably have a G-tube. This is actually what it looks like up here. This is the portion that goes into the stomach, and this will sit right outside. There's a little port right here that you put a small syringe with water, and it fills up, and that's actually what keeps it in there. So when she's pulling the G-tube out, she's pulling it out bulb intact. The only thing you have to do to replace it is just take the syringe, pull out the water, pull it out, lube up the new one, put it back in, and fill it back up, and you're good to go. This is actually a G-tube kit right here. In the event that it comes out, we always have one of these in the car. We have 3 of them at home. And you open this, and it has everything you need short of the water. We have the G-tube, have an extension tube, syringe, and the wee syringe for filling it up with water. This is an extension tube right here. This is what allows us to access the G-tube to be fed. There's a little notch right up here that lines up with the G-tube. It goes right in. You twist it around until it's locked, and you're good to go. This is a port for the small syringe for medications. This one up here is actually for the large syringe where we'll give her water or hook her up to the food pump. We have a little thing that we've got that'll It actually attaches here and attaches to the food pump at the other end to keep it from coming out. And because she still likes playing with it and chewing it, we also have a little thing that Debbie created that goes around it that we snap it closed so she can't get access to it. This is a clip. It doesn't allow anything in or out, so all you have to do is attach something to both ends, unclip it, and you're good to go. When will someone call 911 for a G2? That's not likely to happen. The only true emergencies are the removal of the tube. But more than likely what's going to happen if that does happen is the first parent's going to try and replace it. If that doesn't happen, the patient is going to be driving themselves to the hospital with the child. It's much easier to do that than it is to wait for an ambulance to come and take you. More than likely on the way, they'll probably be contacting their doctor to let them know what happened so that they can let the nursing staff at the hospital know what's going on. This is actually her passed out in the high chair. What you see right there is the food pump. It's on a medical pole with a bag above it. It goes all the way down to, there's the clip, goes up into her stomach. This is the apnea monitor belt up here. That's, looks like the monitor is up here. That's actually a pretty normal position for us. We have the heart rate issues, so she sleeps a lot. 1 hour out of every 4 hours she's eating. She has problems with the contents of her stomach being too much, so we actually do it relatively slow, and we can't increase the amount of food that she gets because she gets distended and doesn't process it properly. So we do what's called a trickle feed overnight, where we will slowly feed her with the pump. Over the course of 6 hours, she'll get 520 milliliters. At roughly 60 milliliters per hour. And that allows us to give her the nutrients that she needs. If you see her, she's actually very lean. She's no fat on her at all. It's not something you really expect to see on a 2-year-old, but she is very thin. It's the only reason we're actually in clothes that are as small as they are. Then at 8 months old, we went to the developmental doctor. It's a pretty normal thing for a premature baby to go to a developmental doctor because they can have a lot of delays. This was the first one that used complicated words like autism spectrum disorder and genetic disorders. We're still working on the genetic disorders. The only thing we know is that there is one. We haven't figured out what it is yet. But at 18 months, we were officially diagnosed with ASD. This is a sign that actually sits on our door right now, because every time somebody knocked on the door, she would go into a full-blown meltdown. It's like the outside world was encroaching on her special spot in the apartment. So we can't have anyone knock on the door. We can't have anyone ring the doorbell. We have this sign outside to let people know. Either call and we'll meet you, or knock very softly. And actually, the ones who do not knock very softly experience the wrath of God with her mother. We had a delivery person that was so terrified of her after he knocked on the door that he handed her the stuff on the other side of the hallway and very, very insistently apologized. Autism spectrum disorder. This is complicated. This is very complicated. Here are some signs and symptoms that you're going to expect. Inappropriate laughing or giggling. They may not want to be cuddled. They will have sustained, unusual, or repetitive play, uneven physical or verbal skills, difficulty interacting with others, spinning objects or the self. She loves wheels. They may prefer to be alone. May have inappropriate attachment to objects. What you will never see is Kyrie away from her blanket, ever. We have crib blankets. We have living room blankets. We have car blankets. The car blankets go with us in the stroller or the car when we go into a store. They probably will not make eye contact. No real fear or danger, or of danger. This is something that we have had so many problems with because she does not perceive danger. She will go straight off the couch without a problem because she just doesn't perceive it to be a problem. Difficult things for needs. She doesn't talk. She doesn't gesture, actually. She doesn't point to things that she wants. She just kind of cries. Over or under sensitive to pain. We do not perceive pain normally. She can slam her fingers in a drawer and just keep going. She's fallen off the table and crawled away at the doctor's office. She doesn't perceive pain the way she should. This is a challenge for an EMS, because how do you do your assessment on a patient that can't tell you what's wrong and doesn't indicate anything is hurting? She'll echo words or phrases. If she sounds like she's talking, she's probably verbally stimming, where she'll just repeat the same syllable over and over again. Insistence on the sameness. Kyrie's environment is important. Her routine is important. If you change either, she cannot handle it. One of our biggest challenges going out to eat, actually, is the constant changing of the table. Objects get put on the table, they get taken away from the table. She had a meltdown once because we decided to split some pancakes, so we cut it in half and put it on 2 separate plates, and she couldn't handle that. Inappropriate or no response to sound. She will not respond when you call her name. She will not. Every now and then she will, and that's just her deciding that she wants to go to you. It has nothing to do with you calling her. To some degree, we have all of these. We're full of boundless energy in spurts. The spurts is more because of the heart condition, where it'll drop and she'll just kind of be left there on the ground, and she'll be very, very lethargic afterwards. Kind of flutters around the room from one thing to the next in a very short attention span, so she'll literally, it's like watching a butterfly, she'll go from one thing to another constantly. She'll want up, and then she wants down because she saw something else, and she'll go play with it, but then she'll stop playing with it because she noticed something else. We use the word manic or frantic a lot with her. But there's a saying in the autism community: if you've met one person with autism, you've met one person with autism. Everyone on the spectrum is different, to the degree that they're on the spectrum and to what they experience while being on the spectrum. This is specific to Kyrie. These are general signs and symptoms, and she does have all of them, but that doesn't mean that everyone that you run into is going to. Day to day with ASD. Not all days are the same, actually quite different. We don't know on a normal basis what to expect. Some days are better than others. She may be affectionate, and she may pay attention to you and be interactive, or she may not. And bad days are very bad days. Some concerns are that she does wander aimlessly, easily distracted by ordinary objects, and people with ASD are drawn to water. This is important. If you ever have a call of a missing child with ASD, first thing you want to check is the ponds, the retention ponds, rivers, lakes, swimming pools. They're overwhelmingly drawn to water for some reason, and actually the majority of the cases, something like 99% of the cases involving a fatality with a missing autistic child, is a drowning. She has obsessive compulsive impulses already at the age of 2. She has certain things that she has to do, and if she doesn't do it, she won't function until you take her back to allow her to do it. The place that I work has a bunch of yellow poles set up in front so cars don't drive into the building, and she has to touch every single one and hug it up to a certain one that doesn't have a cover. She will not touch that one. She might do the one after her, but if you don't let her do that, she won't enter the building. She does not perceive other children as people. They're objects, and she treats them the same way that she treats other objects. She's aggressive with them. She hits them. She pulls them out of her way. If they're sitting on something she wants to be sitting on, if there's a child between her and a wheel, she'll literally crawl over them to get to the wheel. Small changes in the environment have huge impacts, but this is the biggest problem that we run into from an EMS standpoint: self-destructive impulses. Kyrie likes to headbang. Kyrie likes to scratch herself, bite herself. She doesn't perceive pain. We're not sure exactly what she perceives. So she seeks stimulation. It's called stimming. There are positive ones. The hand flapping is a good positive stim. The repeating phrases is a good positive stim. Spinning is another one. The self-destructive impulse is not as much. Some special concerns here. Lights are a great distraction. There was a time I was actually doing an assessment on her because she'd fallen off the couch backwards, anything from a seizure. Hip landed on her head, and she wouldn't actually let me near her head. She wouldn't let me examine it. I couldn't check behind her ears because she wouldn't turn her head. So I took my pen and I went like this, and she turns her head. And then I go like this, and she turns her head again. I don't have to fight with her. I just find a different way of doing it. So children with ASD, play with them. Take your time. You can fight them, and you'll probably lose, and you'll be exhausted and frustrated for it. If you can find a more creative way of doing it, you'll have an easier time and they'll have an easier time. When doing your assessment, start with the feet. I know they say that with pediatrics, start with the feet. This is so important with ASD. It gains a sense of trust with them. It lets them know what's going on, what they can expect. But aside from that, the face and the head area is very personal. Their hands can be very personal. So keep in mind that around the face is probably a no-go area. They probably will not let you touch it. They probably will not let you interact with their head or their face. Have patience. They're going to get distracted easily. Kyrie flitters around the room, so unless she's strapped into the high chair, there's no possible way to do actually any kind of assessment of her. In her high chair, she feels kind of confined, and she's strapped in anyway, so she makes her feel a little more comfortable. On the ground, you will not get her to sit still for 2 seconds to do any kind of assessment. She does not follow commands. She doesn't follow her name if you call her. She does simple gestures. If she picks something up and you go like this, there's a good chance she'll put it in your hand, and that's about it. So be aware that if you have a child with ASD and they're not responding to it and they call their name, that doesn't necessarily mean that there's something wrong with them outside of the normal. If they're wandering around and you're calling for them, they might not come to you. Just be aware of that. When will someone call 911? Same reason as any other child. There's nothing special here, except that many children with ASD also have other problems also. So you might not necessarily be called to somebody with ASD because of that, but be aware that if they have that, they might have underlying problems. That's actually her and her helmet right there. It's something we got for her head banging. Also because she does keep falling out of the couch. So pretty much if she's not strapped into something, she's got her helmet on. Which is okay, it limits sensation for her from the outside world, and she seems to like it, while providing constant pressure. Some other problems and concerns. She has pica. Imagine that. She doesn't eat by mouth, but she loves putting things in her mouth. Spoons, straws, anything plastic, anything metal. She will lick, she will chew. She won't try to swallow it, but she will obsess over it. We have an undiagnosed growth syndrome. We are 2 years old and roughly about the size of a 4.5-year-old. She has cognitive delays. This says that she's cognitive delayed at the 8-month level. The last developmental visit actually said 8 months instead of 10 months. We're actually regressing a little bit. So she doesn't process things the way she should, and she does not speak. She may have cerebral palsy. That's something we're still working on right now. That's something you can't diagnose before the age of 2, so that's something we're starting to look at. And she may have dysautonomia. Now, this is one I've never heard of before I met Kyrie. This is a malfunctioning of the autonomic nervous system. What that means is that anything automatic in the body doesn't function properly. We think that's why she doesn't swallow. We think that's why she has the funky heartbeats. And if she does have it, which we're trying to get a diagnosis, but the insurance won't pay for it right now, she will always be G-tube fed and she will get a pacemaker. Dysautonomia is exceptionally palliative. You don't treat the syndrome, you treat the symptoms. We also have asthma. It is controlled by medications. She does have a hypersensitivity to grass. This is difficult right here. Imagine this. You have a child that doesn't want to sit still, that doesn't like anything on her face, and what do you have to do? You have to give her a nebulizer. This is a fight, and actually best done when she's already asleep. She has dysphagia, which is difficulty or non-eating. She does not take anything by mouth. So what can you expect from her? A child that does not present with normal signs and symptoms at all. She cannot tell you what is wrong. She does not feel pain, and she has never presented with a fever. We had C. diff for 2 weeks, and the hospital did not believe us because she never dropped a fever. The only reason we actually officially found out that she got C. diff was because of stool testing, where they found the bacteria. So what does this mean for you? Never make assumptions based on signs and symptoms present. Just because everything looks like it's fine does not necessarily mean that it's fine. But also you can't go off what's normal. You have to kind of change your definition of normal a little bit. Keep an open mind about what's going on and broaden your index of suspicion. If she's fallen, you can't see anything wrong. Does that mean that there's nothing wrong? Or does it mean that there's something there that you just can't find? We're going to talk about a little bit of other general things now. This is a pediatric pulse oximeter. I don't know if any of you would have seen this in the hospital, but this is how you do this with a baby. The little red light goes right on here, and this actually is a nice sort of neoprene fabric that adheres to itself. Some things you're going to have to be aware of with this is that the baby has to be still in order for it to get an accurate reading. Pen lights work great. Actually, just a regular pen will work. Kyrie loves repetition, so all you have to do to get her attention is go like this. She'll stare at you for a long time until she gets bored. But it works for long enough to get a good reading on a pulse oximetry. So be creative, have fun. Just because you're trying to do something serious doesn't mean that you can't have fun with them. It's rewarding for them and it's rewarding for you. Neonatal blood pressure cuffs. This one's kind of fun. That doesn't look too terribly small up there, but this is what it actually looks like. This is the blood pressure cuff that we had in the NICU. Nothing special with this, except that you need to know about it. So this is actually what they use, and after a little bit we were able to step up to a slightly larger one. But the other one is where we first started. This will be up here also. Now, special needs parents. Special needs parents are a perfect advocate.